a little bit of time with you folks. And if you look at the title of the talk, An Ethical and Practical Approach to Controversial End-of-Life Decisions in Pediatrics and Neonatology, that's pretty ambitious. But let's give it a try for the next hour or so. And I'm hoping that we can give you guys an approach and a language that we can have in common as we try and face some important issues. In general, in pediatrics, and in particular because of this group, there's some issues specific to neonatology I'd like to at least touch upon. So I have nothing to disclose except that I steal pictures from Google, and there's one right now. So just kind of a reminder, and of course, as I talk, I know we have some folks here from neonatology and some folks from the ethics world, and a few of my friends who are both as well. But I don't mean to insult either group as I talk about some of the basics. So very quickly, to sum up pediatric ethics and the problem we have with pediatric ethics in a nutshell is the story of Mrs. Smith. And Mrs. Smith is, she's 29 years old. She teaches social studies at the local middle school. We all know Mrs. Smith. She's a great person. She's very smart. She's got a family in town here. And Mrs. Smith sadly is brought to the emergency room in an ambulance because she's been in an accident. And the physicians in the emergency room say, Mrs. Smith, you've been in an accident and you're badly injured. She says, yes, I know. And they say, we have to take you to the operating room right away to save you. And she says, okay, go. And then they say, and we're going to have to transfuse you in the operating room as well. And she says, no. And they say, but Mrs. Smith, you could die without a transfusion. You all know this story, right? And she says, no, I think it's offensive to God, and I decline the transfusion. Well, if we determine that Mrs. Smith is of sound mind, that in fact, she has the right to refuse a treatment, even a life-saving treatment like transfusion. So as frustrating this is to emergency room physicians, and I've lectured them on this subject as well, the adult docs, most get it. Some are surprised to hear it, but no, we can't force a life-saving treatment such as a transfusion on Mrs. Smith over her objections. Well, a couple minutes later, an ambulance shows up. And who's in that ambulance but Junior Smith? And we say, Mrs. Smith's 2-year-old son. And we say, Mrs. Smith, look, it's your son, Junior Smith. He was in the same car with you. She goes, I know that. They say, he was also badly injured in the accident. We have to take him to the operating room right away to save him. And she says, okay, go. And then the emergency room physician also says, and he's going to need a transfusion to save him. And she says, absolutely not. It's against my religion. I refuse to let you transfuse him. Now, herein lies the problem. I think every pediatrician on this call knows that pediatric ethics is a little bit harder than adult ethics. And this is a reason why. Because Mrs. Smith, when she refuses for herself, exercises patient autonomy, the right to self-rule, right? The right to control what happens to her body. Now, you will hear people use the term parental autonomy. When she refuses on behalf of her son, she's exercising parental autonomy. Though in fact, I think parental autonomy is a misnomer. How can you have autonomy, which is self-rule, over someone else? In fact, what she's exercising when she decides for her son is really, I think it's a misnomer to call it parental autonomy. We should call it parental authority. And parental authority is very strong. She clearly has a right to decide for her child. But it's not as universal, it's not as absolute, if you will, as patient autonomy. But there's going to be some limits to parental authority. And for example, in this situation where she refuses what the emergency medicine physician feels is a life-saving intervention, in that case, the physician, I think every pediatrician on the call knows that if there's no time to the judge involved, et cetera, we're actually going to override her refusal and do what it takes to save this 2-year-old's life. So Mrs. Smith is acting as a surrogate decision maker for her child. And of course, this is a big part of medical ethics, is surrogate decision making. And how do we want surrogate decision makers to decide? Well, in general, in medical ethics, we want to decide based on something called substituted judgment, which is to say, what would the patient have wanted? So when I make a decision for my mother and her medical care, if she's no longer able to speak for herself, I'm supposed to decide based on what I think she would have wanted. Maybe she left a specific document expressing that. Maybe we just had a conversation. Maybe we didn't have the conversation. Nevertheless, that's what I'm supposed to decide based on, not what I would have wanted, not what I think is best, but what I think she would have wanted. That's really foundational in medical ethics. Of course, pediatric ethics is not that simple. For our smallest patients, in particular our newborns, substituted judgment is not possible. We can't say in the case of the 2-year-old or in case of the newborn, what would the patient have wanted? It's not really relevant. So we fall to a different standard, which is patient's best interest, right? And we try to weigh, for whatever the treatment is in question, the transfusion, resuscitation, whatever it is, we try and weigh the benefits and burden of the proposed treatment. And if the benefits outweigh the burden, then we say that's in the patient's best interest. And some folks would say, well, the substituted, the surrogate decision maker, rather, is expected to make a decision based on weighing the benefits and burdens to the child and deciding in the patient's best interest. But really, we've seen that that's not always how it goes. And in fact, there are times when we see that we're not really required, we don't really require the surrogates to decide based on patient's best interest. Now, my colleague Doug Deacon some years ago described what he called the harm principle. And this is a bit different than the harm principle in ethics, but this is the harm principle in clinical pediatric ethics. And what it says essentially is not that we necessarily require the surrogate decision maker to decide what's in the patient's best interest, but we decide them to decide above some threshold of harm. They got to stay above the thresholds of harm. So, for example, if in a given town we believe that the public school is not nearly as good as the private school, and the family can afford the private school, we don't say they must do what's in the child's best interest and send the kid to the private school. In this particular town, the private school happens to be wonderful, and the public school happens to be very poor. Parents could afford the private school. We don't say they're obligated to send their kid to private school. We say that they can send the kid to the public school, even though it's not truly in the child's best interest as we see it. Moreover, they could even do homeschooling. But even if they were to acknowledge, you know what, it'd really be better in the private school, but I want to save my money for other things. The state doesn't send people out to the house and say, you must send your kid to private school. But if what they said is, you know what, I'm not even going to send my kid to public school, I'm just going to let them watch TV all day and eat Cheerios, then we say, you know what, now we've fallen below that threshold of harm. So it's okay for the parents to choose something that's not really what the best interest as we see it, as long as it's above some threshold of harm. You don't have to send the kid to the best school, but you have to educate the child, for example. And there's going to be analogies with the choices that parents make for our patient. So anyway, what's the role of the physician in all of this? How does the physician act? Well, so going back to years ago when I first started studying ethics formally, I started out at the law school at Yale, and I was in this seminar on medical ethics and the law. And it was a marvelous seminar led by a terrific professor. And the seminar had really the perfect mix of students that you'd want. It was half law students and half public health students and one middle-aged neonatologist. So what else could you want for a seminar? So I sat there, and it was a memorable time because the professor presented a difficult case. And I can't remember what it was. It was perhaps, should we or should we not take this man off the ventilator? This man was in the ICU. And he asked the class, who should decide whether or not the man comes off the ventilator? And the class thought silently for a while. And then finally, a woman spoke up, and she was a public health student. I probably work for her now and don't even know it. And she said, well, certainly not the technician. So I thought, the technician, who is she? Oh, she's talking about me when she says not the technician. She felt that it shouldn't be the technician who should decide. And by technician, she meant physician. So sometime after that, I decided to go on and get a degree in philosophy. I went to a nearby university. And on my first day there, for orientation, I met one of the senior faculty. And she asked me, what are you doing here? Because she could see I was a lot older than the other philosophy graduate students. And I explained to her, well, I'm on this ethics committees at some hospitals, and we struggle with these difficult decisions trying to figure out what the right thing to do is. And I thought studying philosophy and ethics might help me with some of that. She looked at me and shook her head, and she said, that's just ridiculous, she said. Physicians should just do as they're told. Well, this was an unfortunate point of view, as far as I could say. I did ask her, tell me the name of the courses that you teach so I could be sure I didn't find myself in there. But this is a relatively popular point of view, that physicians should just do as they're told, that you are, my friends, just a technician. You shouldn't be anybody making decisions. But in fact, we see that we have some, as clinicians, we feel we have some moral agency, which is to say we have some responsibility for our actions. And that really boils down to, in pediatric ethics, often trying to find the limit of parental authority. At what point do we have to say to overrule or seek to override a parental decision? There are a couple documents that kind of help with this as we think through it. One is a famous case from the 1940s at the Supreme Court, Prince v. the Commonwealth of Massachusetts. And it wasn't really about medicine per se, but what came from it was an important statement that medical ethicists often refer to. Basically, that parents have a right to make martyrs of themselves, but it does not follow under the same circumstances that they have a right to make martyrs of their children until such time as those kids can come of an age when they can make these decisions for themselves. This, I think, speaks directly to Mrs. Smith, our friend Mrs. Smith and Junior Smith. The AAP has also said, when it came to issues of life-sustaining medical therapy, years ago there was a policy in the 90s that had beautiful verbiage. I wasn't part of it, but it said, we believe that all children are entitled to treatment likely to prevent significant harm, suffering, or death. Those are two places where we seek to try and identify the limits of parental authority. So if a parent refuses a treatment likely to prevent significant harm, suffering, or death, we actually see it as our place to override them. So shared decision-making should absolutely be our approach. That's where we start out. And 95% of the time, I think we should do exactly what the parents want. And 5% of the time, we've got to figure out there are some things that we must do or must not do, despite our inability to convince the parents on this issue. So how do we decide? How do we decide where those limits of parental authority are? Well, something that's commonly invoked is the standard of care. That's one candidate method. We could look at the standard of care in ethical questions, similarly to we look at them in scientific questions. I would argue that in scientific questions, our obligation to adhere to a standard of care is essentially proportional to the degree of evidence and science that backs up that standard of care. If there's many large multi-center randomized trials that say drug A is better than drug B, then indeed I think we have a pretty strong obligation to adhere to that standard of care and give drug A. If, on the other hand, there are really no trials, but it kind of makes sense physiologically, I'd say our obligation is somewhat less. And if the physiology doesn't even make sense, but it's just kind of our habit, then I'd say our obligation to adhere to that standard of care is less still. There's an analogy, it's not a perfect analogy, but there is an analogy to be drawn with ethical questions. Our obligation to adhere to an ethical standard, I think, is proportional to the ethical arguments that buttress that standard. And if we say that many people got together and considered all the ethical arguments for and against, all the rights at play, all the other considerations, and came up with this standard, I think that that we may well be, to some extent, obligated to adhere to that standard. If, on the other hand, the standard has just been what we decided, we all got in a room one time and just decided this is what we're going to do without any really ethical or philosophical justification for that decision, I think our obligation as physicians to adhere to that standard is something less. So this is the Yale seal here, lux et veritas. I put it to remind me that sometimes I feel that lux et veritas, our Latin motto at Yale, sometimes stands for because we say so, which is poor interpretation of the Latin. But indeed, sometimes we will say to parents, no, we won't do what you ask, or we insist on doing this over your objection. And our justification for that is because we say so. I think we need to do better. So I want to explore that. And in exploring that and in trying to come up with this framework that I mentioned at the outset, this is called the IPO scale for impermissible, permissible, and obligatory. And I first came up with this with my fellow Christy Cummings about 6 or 7 years ago, I think. And we wrote it up then with regard to a particular treatment that was being asked. And just this past year, we actually wrote a nice summary of the whole thing. And what the IPO scale looks at these questions, look at all these questions in this way, that we seek to determine if a treatment under consideration should be considered ethically impermissible, ethically permissible, or ethically obligatory. And we, even within things that are ethically permissible, which is another word really for optional, if you will, some things are inadvisable, some things are neutral, and some things are advisable. But you see, there's a threshold, a red line between inadvisable and impermissible. Inadvisable is something that we're willing to do, even though it's not our first suggestion, our first choice. It crosses over into impermissible when we say, no, we don't think we should do this. And you see the same thing happens on the other side when advisable eventually translates over or transfers over to obligatory. So we're trying to figure out, any treatment. I think it's helpful to us to try and determine which category it falls under, impermissible, permissible, or obligatory. It gives us a way to think about it and also a way to converse about it, to speak with one another as we try and sort these things out. Well, this is pretty easy, right? If it's ethically impermissible, don't do it and don't offer to do it. If it's ethically permissible, offer it, even if they don't ask, even if they're not smart enough to ask. If it's an ethically permissible option, they should be offered that. And if it's ethically obligatory, do it. And insist if necessary, and that could mean going to the court, though you and I both all know that That's rarely really necessary. It's something that we rarely have to pull out, but it's something that many of us who've been around for a while have had to do on rare occasion. So that's basically it. You ask a simple man a simple question and you get the answer there. But we have a little more time, so let's explore a little bit further. Because of course, the real ethical work is trying to figure out how to categorize a treatment under consideration as impermissible, permissible, or obligatory. How do we do this? This is the hard work. And I want to suggest to you that it should be based on prognosis with and without the proposed treatment. We weigh the benefits and burdens of the treatment, and that could include survival. It also includes suffering during and after treatment. And relevant to neonatologists, sometimes that can include things like severe disability after the treatment as part of suffering. So we weigh the prognosis with and without the proposed treatment. So some examples would be antibiotics and a ventilator for bacterial pneumonia in a full-term newborn. Now, if we were all together, we could be conversing about this, but it really doesn't work in this format. So I'll just tell you, I think most neonatologists, hopefully all neonatologists, would say that's ethically obligatory. And again, if you've been around long enough, I've had a family who refused it because they thought that once you're on the ventilator, it proves you're going to die. So I would say that antibiotics and a ventilator for bacterial pneumonia in a full-term newborn is ethically obligatory. So we're going to do that. I would say that gentamicin as a treatment for cytomegalovirus, well, let's think about that. Gentamicin is not going to kill the virus. It's not going to reduce the likelihood of hearing and other disabilities this child might have as a result of that virus. In fact, it could increase the hearing problems. It could increase other problems. So then we have a drug that's potentially toxic that offers no benefit. So the burdens clearly outweigh the benefits. I would say that gentamicin as treatment for CMV is ethically impermissible on that basis, the basis of prognosis with and without the treatment. Now, what's interesting about this, of course, is that location on the line for any therapy is not static. It moves as we get more data. Now, when I was a younger neonatologist, arterial switch for transposition of the great vessels was a brand new procedure. It showed great promise. And I think that though no one used this language then, I think we would have said that, well, it's ethically permissible. We can do it, but it's certainly not obligatory. Well, as the years went by and as more data was accumulated, we see that the arterial switch is an excellent surgical procedure with wonderful outcomes, clearly superior to other options. And so that's actually moved over time from ethically permissible to ethically obligatory. What about a staged surgical repair, the Norwood, for hypoplastic left heart syndrome, compared to just comfort measures only? Well, this is really interesting. On this one, as the data have come out over the course of the years, over the last 10, 20 years, we see the outcomes, the prognosis with the Norwood is better and better. So there was a time when many of us considered it really inadvisable. It was such a hard road for the kid, for the family, and the outcomes were really not clear. Anyway, as time went on, it moved to the right on this scale. And we saw that right now, depending on who you ask, it's either advisable or obligatory. And there's not agreement within the profession or between neonatologists and cardiologists and CT surgeons, as many people on this conference likely know. So I'm going to take a moment now that I'm like 20 minutes into this, and just ask, because I don't have any faces on my screen. This is a different format than I usually use. Sabina, is there anybody still out there?
We have about 114 attendees.
Oh my goodness. All right. Well, I'm glad somebody's listening. Hopefully you're seeing the slides and seeing me, because
we see you.
I'm flying in the dark here, but all right, this is good. Well, thank you all for coming. I appreciate that. So apnea of prematurity is another example of this. What's happened to apnea of prematurity? Years ago, it was an acceptable treatment to treat those kids with supplemental oxygen. Just put them in 100% oxygen. What happened was we got more data, right? What did the data show? And this was actually before my time as a neonatologist. The data showed that putting these kids in 100% oxygen, it actually did reduce the apnea of prematurity, but guess what? It also risked blindness from what we now call retinopathy of prematurity. In those days, I think it was retrolental fibroplasia, right? So it moved to the left. It moved from permissible to impermissible because we got more data, okay? Now, what about extreme prematurity? Things like resuscitation at, you pick it, a gestational age right at the borderline of viability. Some things that might have been considered permissible 20, 30 years ago are now considered obligatory because the prognosis with attempted resuscitation has moved to the right for these tiniest babies. And some things that might have been considered impermissible because there was no chance you could save them now might be considered permissible because it appears there is a chance we could save them. So it's also, for extreme prematurity at a given gestational age, that's also moved. These things move based on change in prognosis. I want to get back to extreme prematurity in a little bit. Right now, I want to talk about another candidate justification for calling something impermissible, and it's futility. It would be futile. Now, who are these women on the right? These are the daughters of the god Danaus, or Danaus, I'm not sure how it's pronounced. They were condemned forever to carry water in leaky vessels. The word futile actually comes from the Latin futilis, which means leaky. It can't work, and it's based on this mythology, carrying water forever in leaky vessels. There's a broad medical consensus, okay, that we have no obligation to provide futile treatment, all right? Well, there's less of a consensus on exactly what futile means. I'm giving you the definition just in simple English. There's a societal consensus, by the way, is less certain. And the use of futility has actually fallen out of favor with ethicists because we as physicians have used it sometimes rather than to explain our rationale, to just shut down conversation. Parents want us to do something, we say, no, I don't want to do it because it's futile. I'm not going to do it because it's futile. Without explaining exactly what's the basis for that decision that it's futile. So I want to tell you the story about when John Fanaroff came to New Haven many years ago. John, are you out there? I think he's out there. If not, I'll tell you the story about him anyway. And John, don't speak up because the story is basically made up. John and I were walking down the beach in New Haven. I put this here because a lot of you haven't actually seen the beaches in New Haven. So this is what New Haven looks like. We were walking down the beach in New Haven when he was here some years back. And we saw these two young boys, very young boys. What they were doing was filling up buckets of water here in the Long Island Sound, picture to the right, and they were emptying it into a hole in the sand, picture to the left. They were going back and forth, and the buckets weren't leaky, by the way. They were pouring buckets of water into a hole in the sand. And when we ran up, Jonathan, they ran up to us and they said, I'm so glad you're here. You look like really intelligent men. And we said, well, yes, we are. We're neonatologists. They said, oh, great. Help us out here. My brother thinks what we're doing is futile, but I say it's not. Is it futile or not? And so, John, don't tell him what you said. John looked at them, and what the correct answer was, which is what he gave him, was this. When asked, is it futile? There's only one correct answer I suggest to you, my friends, and that is, what are you trying to accomplish? And the kid said, well, we're trying to empty the Long Island Sound into this hole in the sand. And John said, it is futile. It cannot accomplish the desired goal. And his little brother said, what are you talking about? We're just trying to get the sand wet so we can build a really cool castle. And John said, it is not futile. Now, can you imagine this? These kids working so hard on a task without ever even discussing ahead of time exactly what their goal was. Fortunately, something so childish never happens in the hospital setting, except when it does. And it's unfortunate, but we often are trying to decide, should we keep, I mean, in adult ethics, we see this, should we keep this man alive on a ventilator? And the question is, well, what is it you seek to accomplish? You want to get him back on the tennis court? Perhaps it's futile. You want to keep him alive for 2 more days because his daughter's getting married today? Maybe it's not futile. We have to stop and think about this, think about the goal. Still, all of that considered, I would suggest to you that the old adage in ethics, which is that ought implies can, is in fact true, which is to say you can't be obligated to do something that you cannot do. So I think that feasibility is actually one of the justifications for saying this can't be done. Okay, so it's related to futility, but we have to be careful about this. We have to have perhaps some data to suggest that something can't be done. Interestingly, position on that line, whether it's impermissible, permissible, or obligatory, is informed by feasibility considerations, including geographic considerations, right? Location on that line is sometimes influenced by location on the map, which is to say that what might be obligatory in Cleveland is not necessarily obligatory in rural Sudan, because we have different resources available, right? And so we have to consider all that. Nevertheless, feasibility is on the list of things that can determine how things get located on the line and determines how things might change on the line. Because some things that were not feasible years ago are feasible now. So we couldn't be obligated to do something that we can't do. That's my point. These things will help determine the location of any given treatment on the line. And there's another thing. Again, this list, by the way, this is my list of what I think determines and changes location on the line. You may have a different list, but we have to have we have to have some consensus of what we think moves it. I think the third thing that locates the treatment are the relevant rights at play, right? So let's think about the rights for a minute. The parents have a right to decide, right? Consistent with my professor's advice, which was physicians should just do as they're told. But we think in the world of pediatrics and the world of neonatology that there's some threshold where we should no longer do as we're told, where we should seek to overrule. And I think finding that threshold is determined in part by an assessment of the child's right in the situation. The child has a right to treatment likely to prevent significant harm, suffering, or death from the old AAP statement, right? The child also has what I've called a right to mercy, which, you know, the term may be something you haven't heard, but in fact, the concept is something that we were all taught and you all know well, which is at some point when we're doing something to the child that is painful and difficult and offers no benefit to the child, I would say that child's right to mercy is such that that determines that treatment is located on the line as impermissible. If I've got a treatment being suggested that is painful and difficult and offers no realistic chance of benefit to the child. So we weigh these things, the right to treatment and the right to mercy. We weigh those against the parent's right to decide. And there may be other rights involved too, the rights of the family members, the rights of society. We think about distributive justice and the fair allocation of limited resources. It may well be that perhaps this child or this adult, it's in their best interest and they want a heart transplant, but in fact, and the surgeon wants to do it for them, but in fact, somebody else is right. Someone else has a greater claim on that resource and how we distribute those limited resources. Eventually, we in the United States will come to grips with the fact that all of our healthcare dollars are in fact a limited resource, and we have to be judicious in how we spend them. So at some point, the rights of other people may come into play here when we locate something on the line. So prognosis, feasibility, and relevant rights are going to determine how something gets located on the line. But there's something else. And to illustrate what I think that something else is, I want to tell you a story from a few years back. It's about ECMO. And I remember when ECMO first became a thing in the world of neonatology, when it was just coming out, it was pretty clear the ECMO teams, including the ECMO team at Yale, didn't feel that kids with trisomy 21 were candidates for ECMO. Well, some years later, I noticed that some kids with trisomy 21 were in fact being offered ECMO. And I thought, well, this is quite a change. I wonder if this is going on nationally, internationally. So Rachel Chapman was the head of our ECMO program at the time. And I said to her and a couple of other my colleagues, let's do a survey. So we reached out to all sorts of ECMO centers and nationally, internationally, 81, you see there. We asked them, assuming a patient meets respiratory criteria, we're talking about newborns here, and there are no other contraindications, would you offer, see, you got about New Haven's sound effect in the background, that's nice. Would you offer ECMO in the presence of trisomy 21? The choices they got were never, rarely, sometimes, usually, or always. And offer to me suggests it's permissible. Remember that zone of permissible is really, it's analogous to what my friend Lynn Gilliman in Australia calls the zone of parental discretion, right? Impermissible, we won't do it. Obligatory, we're going to do it. And permissible, really, the parents have a lot of discretion in there. We generally defer to parental wishes. So offer it suggests that it's no longer impermissible, that perhaps it's permissible. And the results were really interesting. 2/3 of those centers said, yeah, we'll do it. If the parents want us to do it, we will do it. That was quite a change, which led me to ask, what changed? What changed? How did it move on the line? Did the prognosis change? I don't think it was about prognosis for ECMO or the prognosis of trisomy 21 without ECMO. I think there was something else. I think it wasn't, I think it was our attitudes. Perhaps our attitudes about ECMO, no longer a novel treatment, or our attitudes about trisomy 21. And that's where it gets interesting to me as a bioethicist and a clinician. Is there something different about trisomy 21? So let's stop for a minute and consider the concept of moral status. Moral status refers to of an individual, how much that individual's interests should count, right? So we say that a human being has a greater moral status than a dog. Most of us would agree, perhaps not over here. Human being has a greater moral status than a dog, but a dog has some moral status. His interests, if you will, should count too. It's not okay to throw a dog into the fire. About a rock, I would say, has no moral status or much less moral status. It's usually okay to throw a rock into the fire. That's less objectionable to most of us. What about within humans? Are there some humans who are accorded moral status than others in the way we think. And I think we don't have time to get into it today, but I think disability plays a big role on how we perceive moral status and how we reason, and ultimately how we locate things on the line. Who's a candidate for ECMO? Well, a kid who's got normal chromosomes is a candidate, but a kid who has trisomy 21 with the same pathology otherwise is not. Well, why is that? Somehow it would seem that we're differentiating, and I think it has to do with disability. And I would just ask you to consider this in terms of things like trisomy 13 and 18. Again, 20 years ago, 25 years ago, I think very few, if any, major centers were offering resuscitation to infants with trisomy 13 and 18 or ongoing intensive care, ongoing ventilation. But now, as I think you guys probably mostly know, many, many centers do. The line has moved. Many people have moved from impermissible to permissible. Some of that has to do with a better understanding about the outcomes data. Some of it might also have to do with a more nuanced understanding of the influence of disability on moral reasoning. This is, this is just a touch on this. This is obviously a much deeper discussion to get further into that. So I just want to say that what I think determines and changes locations on the line are prognosis, with and without the treatment, feasibility of the treatment, relevant rights at play, and our attitudes about moral status, about disability, about equality. And with our attitudes, I'd say that this is a bit of a warning. It's a bit of a warning. We have to be aware of that. We have to know, we have to consider, am I locating this online based on some prejudice I have about disability or about something else about this particular child? But our attitudes may indeed help influence how we locate things on the line. And that's a bit of a caution. Whether or not they should is a separate question, but they do. So how do we fail to get it right? I think we fail to get it right with questions of transparency, honesty, and justice. So with regard to transparency, I think we should be transparent with the parents about diagnosis and prognosis always. And all reasonable options, including those you don't recommend, and the likely outcome of each should be made available to the parents. Even what's available elsewhere if transport is feasible. If you've got a procedure that you've done 3 times in your place, and it's been done 30 times at some place that's transport is easily feasible, I think the parents deserve to know that. The savviness requirement is a really important one. And what I mean by the savviness requirement is this. I mean, an anecdote I would tell you that some years ago, I was in conversation with a group of folks, and I asked a surgeon, would you offer this surgery for this child? And the child had a certain disability, underlying disability. And the surgeon said, I wouldn't offer it, but if the parents asked for it, I'd be willing to do it. Well, I thought that was a real problem because, of course, if the parents were physicians or nurses or had relatives who were physicians or nurses or who were really good with the internet, they might know that that's an option if they were savvy enough to know these things. If the parents had no family members in the medical profession, weren't good with a computer, they might not ever know that that was an option they could have asked for. So I don't think we should offer things to people only because they have to be, only if they ask for it. They shouldn't have to be required to be savvy in order to get ethically permissible options made available to them. Another place we fall short is honesty. So here you were hoping to get a quote from Shakespeare. So here it is, the one Shakespeare play I read in high school, and maybe since then, which was Hamlet. And when the young man is leaving town and the old man, his father, is giving some advice before he goes, he says to him, this above all else to thine own self be true, then it must follow as the night the day, thou cannot be false to any other man. Well, what was he saying? He was saying, I think, be honest with yourself first, then you can be honest with other people. We have to be honest with ourselves about the diagnosis and about the prognosis. And I mean, I've once heard a physician quote numbers that were far from the data because he was trying to make the point that they shouldn't choose this option. There's only a 1 in 100 chance it could work. Now, really, it was about a 1 in 10 chance. Why did it say 1 in 100? Well, I was trying to show him that was a really bad idea. Well, then tell him it's a bad idea. But don't disguise your opinion about whether it's a good or a bad idea with data. Okay? Avoid opinions and value disguised as data. Right? We have to be aware of our own perceptions and values and how they might be influencing where we think a treatment falls on the line. That honesty with ourselves includes honesty about our values, about such things as disability. The self-fulfilling prophecy is another important thing about how we delude ourselves. Some years ago, I was giving a visiting lecture. It was before 2005, and I asked the folks at the place then. I said, "Are you guys resuscitating at 22 weeks?" Because some people were now talking about it. The Japanese had published about it. I said, in the United States, it seemed like a relatively rare procedure, attempted resuscitation at 22 weeks. So I asked them that, and they said, And the chief at the place I went to said, no, absolutely not, we don't. I said, oh, good, someone's figured it out. Tell me why you don't do it. And he said, because we've never had a survivor. And I thought, well, that's a little bit circular. I didn't say it out loud, but I thought, you went to high school, right? I mean, that's kind of circular reasoning here. I mean, that works at 28 weeks too. If you never try and save them, you're not going to have a survivor. So that struck me as rather odd. And this is the careful. We have to be careful and be honest. What do we know about survival? For example, what did we know about survival at 22 weeks if we really tried? We didn't know much in 2004, 2005. And we need to be honest.
You muted yourself. You're muted now. We didn't hear the last slide.
I should be unmuted now, am I?
Yeah.
Yes, you are.
Yes.
That's very
good.
strange. All right. So I apologize. I don't know how that happened. I didn't touch the thing, but all right, fair enough. Justice is another place we could go wrong. Justice by Aristotle suggests that we should treat equals equally. Looked at another way, if we're going to treat people differently, we should identify a morally relevant difference. I think that morally relevant difference should actually be a difference in prognosis. Not because one is one ethnic group and one is another. One looks like my family, one doesn't. I think it should be that morally relevant difference between patients is about prognosis, not about other things, not even about something like gestational age, and we'll get to that. Equal treatment should be our default position. But let's talk for a bit about, no, that's curious. Okay, there we go. Let's talk for a bit about borderline viability, right? At extreme prematurity, where I think there's a potential for injustice. Now, years ago, decisions were based on gestational age or birth weight, and for many people, they're still based on gestational age. Now, back in 2008, John Tyson and the folks at the Neonatal Research Network published a marvelous paper in the New England Journal, where they said that intensive care for extreme prematurity, the title of the paper was moving beyond gestational age. What they showed was that you can do better with predicting outcome than using gestational age if you use gestational age in addition to birth weight or estimated fetal weight, right? The sex, plurality, and the presence or absence of antenatal steroids. Well, we knew that the girls do better than the boys, the singletons do better than the twins, kids who got steroids do better than kids who don't get steroids. All of this should factor into it. And so, of course, they created what's called the outcomes estimator, right, on the NICHD site, which puts those 5 factors in. And based on those 5 factors, you can get a likelihood of survival. This was updated very recently, and it's based on a large data set that's relatively recent. And in 2015, Matt Rice, again, with the folks in the Neonatal Research Network, again, published this update. And we once again saw that those 5 factors are clearly better than any one alone, including gestational age, at giving us a prognosis, which is where I think we should locate things on the line. So here's an interesting fact. Impermissible, permissible, and obligatory, right? That's our IPO scale. Notice these incredible graphic skills that I figured out yesterday where I can actually draw a gray there in the middle for permissible. That's the gray zone, what in neonatology we sometimes call the gray zone. And that kind of means, well, we're not so sure, and so we let the parents decide. So interesting, let's look at prognosis. A 23-week male at 450 grams, singleton, no antenatal steroids. It's got a 15% chance of survival if we try, and a 52 to 78% chance of moderate to severe disability, neurodevelopmental impairment. A 22-week girl, other things being equal, has a better chance of survival. And yet if some people would go by, and we all did it for a time, go by gestational age alone, we might offer the parents of that 23-week boy the option of attempted resuscitation, but not offer it to the 22-week girl, even though her prognosis is probably a little bit better. It's at least as good. That to me is an injustice. That to me is a fundamental injustice. Now, it gets more interesting. A 25-week male who's 700 grams, singleton, antenatal steroids, we see his chance of survival is 74%. Now, the 24-week female, she's got the same prognosis, other things being equal. Now, also, at that 24-week female, if we consider that within the gray zone, some folks would say, well, the parents have the choice whether we try resuscitation. But for the 25-week male, who's got essentially the same prognosis, maybe slightly worse, we say, well, the parents don't get a choice. Now attempted resuscitation is obligatory. Again, I think that's an injustice. I think if we're going to treat these people differently, we need a morally relevant difference. And I think the morally relevant difference is prognosis, which we see in these examples. It's not different. So I don't think we should treat a 22-week girl differently than a 23-week boy, or a 24-week girl differently than a 25-week boy. Well, where are we on this? I mean, so Tyson pointed this out in 2008. Rice-Havey in the same group reiterated it in terms of our ability to better predict outcome with those 5 factors. So if we look at the most recent issue of the NRP, they say the guidelines are complex and developing. And in previous issues, they did say basically 22 to 24 weeks is the gray zone, and we defer to parents. In the most recent issue, I was hoping they could say it again so I could say that they were wrong, but in fact, they didn't. They didn't put specific gestational age weeks. Now, the AAP, most recent guidelines from the Committee on Fetus and Newborn, does still say, basically, as you see from the quote here, that for them, 22 to 24 weeks is still a gray zone, if you will, and this is largely left to the parents to determine. You can read the quote there. But it's still based on gestational age when they write about when we should or shouldn't provide resuscitation. Well, the IPO framework suggests guidelines should be based on prognosis, consistent with the work of Tyson and Rice-Havey. Now, just in 2020, Brian Carter and I wrote a paper, Resuscitation Policies for Extremely Preterm Newborns, finally moving beyond gestational age, with apologies, or more on, not really apologies, but a tip of the hat to Dr. Tyson, that they've shown it and shown it again that we shouldn't just be using gestational age. If we want another prognosis, we have better tools to do that. And in the most recent, in the current up-to-date entrance on borderline viability, it says the same thing. And that really reflects what our policy is here at Yale because we wrote it. Doesn't mean it's the right answer. It is what I think is the best approach. So not every decision is life and death. So we're talking about resuscitation at extreme prematurity, and that's interesting. But keep in mind, there's other stuff that's not life and death, but is also kind of interesting. And we're still trying to work this out. How about the newborn screen, right? The little heel poke that you do. Is that obligatory or is that advisable? Here, we certainly know it's advisable. We want to do the metabolic screen. But here in Connecticut, it's actually obligatory. The law says we have to do it. What about vitamin K? Now, vitamin K, we certainly advise it. We want that kid to get his vitamin K shot, right? Now, what are the chances that's actually going to save the kid's life? What's the prognosis like with and without the treatment? Well, is vitamin K going to save his life from hemorrhagic disease of the newborn? Probably not. He probably wasn't going to get hemorrhagic disease of the newborn. There was probably 1% chance or less that he would get hemorrhagic disease of the newborn. Okay, so if there's a 1 in 100 chance that an intervention could help a child significantly, should that be considered obligatory? In other words, should we do it over parents' objections? Because now we sometimes get parents objecting to vitamin K. An interesting question. What if it was 1 in 500? What if it's 1 in 1,000? This gets us to the question of sepsis evaluation. We all have these algorithms, right, for whether or not a patient should get a blood culture and antibiotics based on his risk for early onset sepsis. We're talking about asymptomatic babies. I've got an asymptomatic baby, and we do some calculation, and based on this, I don't have the numbers in my head, but we went through this recently here. There's a 3 in 1,000 chance this kid's going to develop early onset sepsis. Therefore, we want to do a blood culture and start them on antibiotics. Okay, and that's what we recommend. Now the parents refuse the blood culture and antibiotics. It doesn't often happen, but it happens. Now the parents refuse that. What are we to do? Is that advisable or obligatory? Is it likely to prevent significant harm, suffering, or death? Certainly not. There's maybe a 3 in 1,000 chance it's going to prevent significant harm, suffering, or death. What should we do about these newborn screening? And I hope we have a few minutes afterwards, because I'm open to suggestions. We're still trying to sort this out, which things we should consider obligatory and which things we consider permissible. Life-saving treatment is easy. But the stuff that is a small chance that it's going to save a life, it's hard to know what the threshold should be, where to draw that red line on the right? A low risk of adverse event, but a high degree of harm if it occurs. So I talked to a hospital attorney about this last week, and she said, well, if there's a chance the kid could really get in trouble with sepsis, then of course you should do it. And of course, if he gets septic, yeah, he could get in real trouble. That's easy. Or if he's acting septic, I consider that obligatory. But if a kid who's asymptomatic and has these risk factors, it's an interesting question. What's our threshold? 1 in 100, 1 in 500, 1 in 1,000? At what point is it no longer obligatory? If we had a test that had a 1 in a million chance of actually saving a child's life, and it involved some pain, and the parents said, I don't want you to do it, would we still be obligated to do it? I'm interested in your thoughts on that. We need to find that threshold between advisable, and obligatory. And it's not easy. So the common errors when we use this, just to wrapping it up, don't mistake inadvisable for impermissible. Don't mistake advisable for obligatory. Choose your battles. Parents deserve to know all permissible options, and remember it's dynamic. We can't say we figured out in 2021 what the right answer is for a certain treatment, and then think that we've got it figured out for 2022 or 2023, because as more data become available, things can move on the line. We got to function as a team and think ahead, right? So if you guys are trying to figure out what your policy should be for extreme prematurity, you don't decide that at 4 o'clock in the afternoon when a woman comes in and she's about to have a baby, and you say, well, I'm willing to resuscitate the baby if you want, but my buddy comes on at 5, he's not going to do it. But if you wait till tomorrow morning, my other partner, she's willing to do it. So if you don't have the kid by 5, try and hold. No, you can't do that, right? You got to be on the same page. You got to sit down as a team, go over all the data, go over all the ethical issues at play, listen to each other, and then come up with a plan that you can all live with. To make this system work, we need communication, we need compassion and empathy. And lastly, we need professional humility and to make that IPO system work. And by professional humility, I mean really 3 things. First and foremost, admitting what you don't know. And we're trying to talk about prognosis. Sometimes we just don't know. So rather than saying this can't possibly work, so therefore I won't do it, if we don't know if it could work or not, we should say what we're basing our opinions about prognosis on, right? We should admit what we can't do, always. And the last thing has to do with, of all people, Vince Lombardi, the famous football coach of yesteryear. Some of you know that Vince Lombardi coached the team, the Green Bay Packers, that won the first couple of Super Bowls. The team that wins the Super Bowl every year wins the Lombardi Trophy. He was an interesting coach and had lots of great philosophies that he shared with everybody that ended up posted on all these boys' locker rooms in the 1960s and 70s, and probably screwed up a whole generation of boys. But that's okay, because he had some ideas that were really quite good and quite insightful. And he had one thing that speaks to professional humility, and it speaks to our obligation here. It was, they asked him, he used to make his players run a lot in practice, and they said, why do you make them run so much in practice? Football is a strength sport and a skill sport. It's not an endurance sport. What are you doing? And he said, I make them run a lot in practice because I never want them to get tired in the game, he said, because fatigue makes cowards of us all. Fatigue makes cowards of us all. Truer words were never spoke. So the third part of professional humility is to admit to ourselves what our motive is when we decide that we insist on doing something, or when we decide we refuse to do something that parents are asking us to do. Am I saying no because I really think it's not in the child's best interest to do it? Am I saying no because I don't think it's feasible and can't work? Or am I saying no because I'm tired? And if I'm saying no because I'm tired, that's absolutely understandable. Okay, I'm a human being. But at that point, what I have to do is to get someone else in there who's not as tired. Fatigue makes cowards of us all. That's a possible reason for saying no to a parent's request. It's not a justification for saying no. The last point I would make is moral agency. And I would say that we have to remember we're moral agents. I disagree with my professor, my philosophy professor, who said physicians should all just do as they're told. I think we should usually do what the patient or the patient's family wants us to do, but not always, because ultimately we're moral agents. We're responsible for what happens in our unit. So it's okay sometimes for us to insist, or sometimes for us to refuse. But we have to have a better justification than just because we say so. So with that, this concludes the talk. I want to thank you all so much